microbiology of it, there are a lot of microorganisms which are responsible for early onset VAP is usually caused by the antibiotic sensitive, but in late VAP is usually MDR pathogens, and that is why there is a high incidence of higher mortality. Nowadays, even the reports of early onset of VAP is produced by the MDR pathogens are also increasing. And in this context, where we have carried out the studies, there are various organisms which are responsible for this VAP: pneumococcus, H. influenza, MSSA, Enterobacter, Proteus, Klebsiella, E. coli, and Serratia. While for the late is what is happening that MRSA is nowadays more common, Pseudomonas, Acinetobacter, and new organisms like ESBL producing organisms which are found to have a resistance to the carbapenems are coming up. This is a study which was conducted in Lady Hardinge Medical College and SKH Hospital in Delhi. What we found that we found Acinetobacter and Pseudomonas in high incidence, followed by E. coli, Klebsiella, and Staphylococcal, and H. influenza. The interesting factor is that Acinetobacter, which was causing VAP, were found to be MDR resistant. The diagnosis is based on, there is no clear-cut presently still available universal guidelines. The available methods lack both sensitive and specific diagnosis. Beside the daily evaluation, along with the chest radiographs, can help to suggest whether there is a presence or absence of VAP, but it does not define it. Rather, it is said that nowadays radiograph is not considered important for the diagnosis. American Thoracic Society and IDSA guidelines recommended obtaining lower respiratory tract sample for cultural microbiology. This is the gold standard of diagnosis. CPIS, that is a clinical pulmonary infection score, takes into account of clinical, physiological, microbiological, radiographic evidence to allow a numerical value to predict the presence or absence of VAP. All these 4 parameters has to be taken, and a total score. If the score is of more than 6, then there is a good correlation of diagnosis of VAP. Still, there is a sensitivity and specificity is still low. So diagnostic dilemma is there of diagnosing the VAP. CDC surveillance criteria. What it defines two entirely possible and probable VAP. A period of at least 2 days, as I mentioned earlier, of a stable or decreasing ventilator setting, which is decided by the clinician, followed by consistently higher setting for at least 2 additional calendar days. So that if the patient is continuing to deteriorate on the ventilator and then patient requires more of ventilative supports, it is suggested to suspect that patient is likely or he has a possible VAP. And then once other parameters like radiological parameters are taken into consideration, culture sensitivity, that will prove whether the patient has a definite ventilator acquired pneumonia. Most common causes of VAP are which causes ventilator associated conditions, deterioration, are like pulmonary edema, atelectasis, and ARDS. So ARDS may not be the initial manifestation, but it can mimic the picture of VAP, because ARDS can occur also in the setting of septicemia. So signs of infection, anti-inflammations classify the patient as an infection-related ventilator-associated complication or IVAC. Patient with IVAC and purulent secretion alone or pathogenic alone have a possible. So diagnose a possible pneumonia if the patients with IVAC and there is a purulent secretion. If these 2 alone are there, still it is possible, and if it is supplemented pathogenic culture, then it will come to be a probable. Probable pneumonia is also defined by suggestive histopathology. In some centers, they mandatory make it possible to take us histopathological features from the tracheal aspiration. Similarly, positive pleural fluid cultures, the patients who develop pneumonia are likely to develop syn pneumonic effusion, and then if you aspirate the pleural fluid and get a culture, then it gives a more diagnosis of VAP associated with pleural effusion. As I mentioned earlier, chest radiograph findings have been excluded in the new criteria because it was quite misleading. So treatment of VAP is usually select an appropriate antibiotic, depends on the duration of mechanical ventilation. An updated local antibiogram for each hospital and each ICU based on local bacteriological parameters and susceptibility is essential to guide optimally dose initially. So there is a role of treatment of pharmacologists as well as microbiologists with the clinician to find out what is the pattern of organism which is occurring, developing VAP, and what is the pattern of antibiotic resistance which is affecting the overall prognosis in patients of ventilator acquired pneumonia. There are various antibiotics which have been usually used are early onset. Mostly they are cephalosporin sensitive, so cephalosporin good drug. Fluoroxylenol, which you normally use even in community acquired pneumonia, levofloxacillin, they have equally good role in early onset VAP. Beta-lactams, yes, it's found to be very effective, and carbamazepine is the last but most effective in the early onset. But in late onset, because of nowadays beta-lactam antibiotics and some gram-negative coverage for like aminoglycoside and fluoroquinols, along with coverage for MRSA, are the usually three common antibiotics has to be used for late onset because they have a more of multi-drug resistance pattern. Doses in late onset VAP, we usually normally extend cipamminum 2 gram every 8 hours, carbamazepine in the dose of like meropenem 1 gram every 8 hours, beta-lactam and beta-lactam inhibitor, piperacillin, tazobactam 4.5 grams every 6 hours. Yes, we have to also monitor the renal functions, and depending on that, you have to modify the dose. In aminoglycoside, piperacillin, tazobactam. Other drugs which are, as I said, in early as well as late is ciprofloxacin, vancomycin. Linezolide is found to be very effective in some microorganisms. So duration is usually 8 days in early onset, but longer, maybe 3 weeks to 1 month in late onset MDR resistance ventilator acquired pneumonia. Now in this context we carried out the study. The objective was to find out the associated local microbial flora and evaluate the factors of high mortality rate in patients with VAP. We conducted a study on 60 patients over a period of 1.5 year duration between the age of 18 to 80 years. The study population consists of patients expected to be mechanically ventilated for more than 48 hours. CDC definition, as I mentioned, was considered for the diagnosis. Study protocol was approved by the ethical committee of the institution. Patients with ARDS are not fulfilling above mentioned inclusion criteria, like patients who had earlier septicemia developing ARDS were excluded from this study. A detailed history, clinical examination, and followed by relevant investigation required to make the diagnosis, as I mentioned earlier. Certain baseline characteristics of all the participants record like age, sex, and other thing, and then informed consent was taken. Even informed written consent was taken from the relative of the patients, because patient was on ventilator, or the earlier patient who was before putting on his conscious, the consent was taken from that patient who was likely to be on ventilator for later period of time. Variables related to diagnosis of VAP and other important parameters noted in ICU like CBC, PO, ABG, character of tracheal aspirations and tracheal aspirates, and pleural fluid analysis were done. Though we have taken a sequential chest radiograph, but this was not the important diagnostic point, but we have followed it for the clinical improvement in cases of early onset and those patients who responded even in late onset ventilator acquired pneumonia. So clinical diagnosis of suspected when the patient showed a new progressive persistent infected on chest radiograph along with fever, leukocytosis, purulent tracheobronchial secretions, and identification of organism done by biochemical tests as per the clinical laboratory standards institute guidelines. Data statistical analysis, data was compiled and analyzed by using Microsoft Excel SPSS version. We have expressed as the frequency and percentage. Continuous variables are presented as a mean and standard deviation. Test of significance were applied using following tests like a chi-square state with Yates correction, and difference of proportion were applied for quantitative analysis. Mean and standard deviation between the two groups compared by independent tests. ANOVA analysis was also been used to compare means between the 3 or more groups. Now coming to the results, what we noticed that out of the 60, 40 were male, 20 were female. So proportion of male patients was more. Mean age was of 49 plus minus 13. in male and 42 plus minus 14.35 in case of female. The mean BMI for the patient was 20. So average build patient usually will found. What another important is that Acinetobacter was found to be the most prominent isolate, followed by Pseudomonas, E. coli, Klebsiella and Staph. Pseudomonas aeruginosa showed, now coming to the sensitivity pattern, they were shown to have a high sensitivity to imipenem, colistin followed by meropenem. But the interesting fact that even in these patients, there are 15% of patients almost who had resistance Pseudomonas aeruginosa. Acinetobacter was sensitive to antibiotics in order of colistin, imipenem, meropenem, linezolid, amikacin up to 70%. So the study other part is showing that probably 30% in cases where Acinetobacter found to be resistance to many antibiotics. Klebsiella similarly were more sensitive to imipenem. So almost if you look at this slide particularly, from 15 to 30% there was a resistance of this organism to even a new generation of antibiotics. MRSA, fortunately this is after the introduction of linezolid, MRSA were found to have 100% sensitivity and there was a good sensitivity to vancomycin. So in patients who earlier used to have a vancomycin resistance, we have got a very good drug, this linezolid, which has helped the clinician to tackle with the MRSA. The most effective antibiotic for E. coli were imipenem and meropenem. So the key point was, as I mentioned earlier, Acinetobacter was most predominant isolate from tracheal aspirate, accounting for almost 33% of cases widespread. The incidence of early onset in this study was 26%, but incidence of late onset VP was very high, that was 73%, with a mortality as high as 81%. So what we normally notice that if the patients, as I was discussing it, because regular uses of early uses of antibiotic, as soon as the patients come into the ICU, the clinician have a tendency to put them on cephalosporins and other drugs. So they try to tend to develop earlier treatment, but later on, if the patient remains on ventilation for a longer duration, they develop late onset VAP with a multi-drug resistance organisms, and then the mortality becomes very high. We have compared this study with the relevant other comparative studies. If you notice here, the incidence was quite equal in all the three things, but the mortality, if you see it, is almost 25% in early. But you can see even in the Western setup and European setup, the mortality is still high compared to the Asian is definitely in India, we have a very high mortality, but even in Europe and USA, you can find out that the incidence is very, very high of mortality. So what is the message? Like we see that Acinetobacter is the #1 organism, but what is more important, they are resistant to most of the first line antibiotic used in the hospital setting, like ceftazidime, gentamicin, amikacin, ciprofloxacin. And now there is gradual resistance developing even carbapenem like imipenem and meropenem. So now with this we find that probably it is now the time has come that as a pharmacologist we need to find out some better drug, though there are other criteria of reducing the overall incidence of ventilated acquired pneumonia. But beside that, some antibiotics should be available in armamentarium of the clinicians so that patients who develop a late ventilated acquired pneumonia can be salvaged. So this is again the same thing. There is an emergence of resistance of this antibiotic developing fast, and the basic message is new need for newer antibiotic for particularly yeast-built type of organism is required. Thank you very much. If any questions you have.